Welcome to the MEF2C cast, a podcast dedicated to educating, supporting, and building community around MEF2C haploinsufficiency syndrome.
The MEF2 Cast is for informational and entertainment purposes only. Views expressed are those of the host and guests and not necessarily of the podcast or its sponsors. This is not medical advice. Consult a healthcare professional for medical concerns.
Alrighty, hi everybody. Welcome to the MEF2C cast. Our guest today is Dr. Zachary Grinspan. He is a pediatric neurologist. He's the director of the Pediatric Epilepsy Research Program at Weill Cornell Medicine, and he is co-PI, that's principal investigator, for the Volāre study, which is a MCHS natural history study that probably most of the people listening are familiar with. So how are you today, Dr. Grinspan?
I'm great. Thanks so much for having me on the show.
Oh, thanks for coming on. So, can you start by just telling us a little bit about how you got started in kind of MCHS research?
Sure. So while Cornell Medicine has several programs related to pediatric neurogenetics, genetic conditions that cause developmental brain disorders, the leaders of some of the foundations came to us looking for partners. There's an existing partnership with the folks down at Medical University of South Carolina with Chris Cowan's group to
Mhm.
develop therapeutics. But in thinking about delivery, like once you make a drug, how do you give it to kids? How do you track them? How do you see whether they're better or not? How do you measure that? How do you convince a regulator that your drug works? And so they were looking to us for thoughts about that. I happened to be on the phone call. It became immediately obvious in listening to what people were asking for that they needed a natural history study. There are some drugs that you give it to kids and there's immediately a huge response. But for most rare disorders, the responses can be a little bit more subtle. It's not always so obvious whether a drug is working. It can take some time. And then one of the major challenges in developmental brain disorders is that you have this constant tension between the gene, often it's a genetic defect, working to slow down development, and then these natural processes that are making development go ahead. And so you never know how that tension is going to work out with time. But I pitched to them and said, listen, why don't we get to know some of the people with MCHS, track them over time, see how they develop without a drug, so we know what the baseline is, and then we know it really well using these regimented assessment tools so that we have numbers, so we really understand what the trajectories look like. That idea was enthusiastically received. So we put together a proposal to do that, and we've launched. The Volāre study is what it's called. The structure is that there's a foundation called the Rare Bird Foundation, and so the funding is coming through that. But the community has been absolutely wonderful to work with. The leadership, James Kelly and Isra Bhatti have been my primary contacts, and they're both parents. They're devoted advocates, and they're very effective at helping our study get launched, helping it stay on time, helping us find people to enroll. But that's sort of at a high level how I got involved and how this whole thing got launched.
Yeah, that's great. One of the other things, as I understand it, about a natural history study that's helpful too is like if you go to the like FDA, that's what I
Hmm.
was trying to think of, and you say, I want to try this drug for MCHS, they're going to look at you and say, well, what the hell is MCHS?
Right.
So we also just need data to be able to characterize this disorder accurately, so we can even begin to approach treatments for it.
Yeah, exactly right. And this kind of data will provide that with a lot of granular detail. So it's not only what are the signs and symptoms and how do kids look at a moment in time, but how does that evolve? And we're enrolling kids of all ages. The younger kids we're bringing here to New York. The older kids we're doing virtual visits to understand their stories. And it's really at a lightning pace where we've seen 8 or 9 kids so far here in New York. We're scheduled to get that number up to the mid-20s currently, and our goal is by the end of the calendar year to have 36 enrolled. What's nice about the clinic, all the folks that are there that staff our clinic, we're all clinicians, right? Like we see patients as our day job, and then we're able to do research projects on the side. We get some funding. We've got the infrastructure here. So even though people are coming for these research visits, they're getting care. We're giving them advice. They're often seen by a developmental pediatrician. We have a physiatrist that comes to some of our clinics, occupational therapy, geneticist, and they're all both gathering data, but also giving some advice. So I think the families get something out of it. Certainly, we're learning a ton as these families have donated their valuable time to come and visit with us. But I hope at least that it's a two-way street, that we're providing some value to the families as well.
Yeah, everyone that I've either talked to directly or have seen talk about it has said that it's gone really smoothly. At the very least, it's not a burden on the families. So
Good, good, good.
that's very good to hear. So can you talk a little bit about, and for our audience, I ask this for every expert just because I think it's helpful to hear different experts explain the same thing different ways.
Yeah.
So, can you just sort of give a basic overview of MCHS in terms of like the MEF2C gene itself and the actual protein, what it does in the body?
Yeah, and I should, MEF2C is a gene that's involved in developmental processes. It's a regulating gene. The more, I'm not a basic scientist, I'm a clinical
Right.
scientist. When I read about it, it seems like people have had different theories about what the gene does and what it's responsible for. So I would frame it maybe thinking more broadly that there's a group of disorders like MCHS, that we call the developmental and epileptic encephalopathies. DEE is a little easier to say. And these are disorders where there's often a genetic problem. Sometimes it's very obvious why the gene would cause a neurologic developmental set of symptoms, but sometimes it's not. With MEF2, it doesn't seem that obvious, like why this particular gene it causes such problems. But the story is very similar for these genes, regardless of sort of what their particular function is in the cell, where you have kids who have some combination of developmental delay and seizures and epilepsy. And not everyone gets both. Like with different genes, sometimes it's seizures only, sometimes it's developmental delay only. What's unique about this group of disorders is we think that the seizures make the development worse. And so, whether it's the abnormal EEG findings or the seizures themselves, seem to make everything harder. And so, what's nice about that is that there's been a lot of thought in the epilepsy community about how do you track these disorders over time? What are the right instruments? What are the right things to measure? And so MEF2C fits nicely into that larger bucket. So what's been, and I think, helpful for us as we designed the study and executed it is that the children with MCHS look very similar to many of the other kids with these other genetic disorders. And we have this battery of instruments sort of ready to go to do the measurements. So when I think about the specific mechanisms, I think more sort of more as the clinician saying like whatever it is that it's going wrong. As Chris Cowan's group starts developing these therapeutics, are they going to be able to show that their therapeutic ideas are leading to improvements in their cellular and animal models? And that's what we're really excited for. So I'm talking a little bit around it. I'm not a basic scientist, and so those specific cellular pathways and mechanisms that
Sure.
MEF2C are involved in, there seems to be a couple different stories. But if we can fix the cellular pathology, that gives us some hope that we can fix things in humans. And then if it's safe, they often will give it to mice models and sometimes to small mammal models, either pigs or monkeys. And we get that safety signal that things look okay, then we can try it. And then what's lovely about the natural history study is we'll know what people look like without therapy. And so
Mhm.
we'll see if they get a bump, advantage in their developmental trajectories and with seizure control for the kids who have seizures.
Do you Is there any like clear or unique cause about seizures specifically with MCHS? Or, I've heard people talk about the excitatory inhibitory imbalance. Is that sort of like the what am I trying to say? Is there anything unusual to MCHS relative to seizures, or is that just sort of the basic explanation?
Yeah, so far they haven't seen particularly different than some of the other DEEs, some of the other developmental and epileptic encephalopathies. So, we're one of the things that we want to start doing later in the fall is collect EEG data, and we've developed a battery of these analytic tools that can take the EEG data and look for different biomarkers, look different signals that may be specific to MF2C, or at least give us some baseline so we can see if the abnormalities improve with the drug. The one thing that I will say, I've been impressed by um, some of the disability related to hand use. Um, There's another disorder called Rett syndrome, and many
Mhm,
of those kids have these characteristic hand movements and sort of challenges using their hand in particular
mhm,
seem to be rough for those kids. And with the MCHS kids, I've gotten that sense from some of the other kids and some of the other families. The challenge is, I think it's often tempting as a clinician to say, "Oh, I know this disorder and I can distinguish it from the others." But I'm always wary of people who say that for a few reasons. One is that the disorders often look very similar one to the next. And second, what I'm anticipating we're going to find, and we've already found to some extent, is that there's often a very wide range in disability and in symptoms. That some kids would be more impaired than others. Some kids have a lot of seizures. Some kids have few, if any, or none. And so it often ends up being very hard to distinguish the disorders clinically. But with that said, you need those numbers, you need that baseline so that you know how everybody develops over time.
right. Can you explain, just for anyone in our audience who might not be familiar, that excitatory and inhibitory balance that I mentioned
Yeah.
earlier?
Sure. So there's a couple of different flavors to it, but seizures I think are the most dramatic. Your neurons in your brain are always communicating with one another, and at a high level there's two kinds of signaling that each neuron does. There's an excitatory signal and an inhibitory signal. The excitatory signal is typically glutamate, the inhibitory one is typically GABA, although there are some others. And so one way to think about a seizure, for example, is that suddenly there's this, the floodgates have opened on an excitation, and suddenly all the neurons that are normally in balance are all firing, and they're exciting one another, and you get this sort of domino effect where all the neurons start to fire, and they're in a network, and so that firing becomes synchronous. And so for someone who's having a seizure and you see that rhythmic shaking, that's this excitatory overload, basically, where all the circuits are firing in synchrony. And then to shut that down, you have to have a bunch of inhibition. First of all, the neurons get tired because they only have a certain amount of energy, can only fire so much. And then the brain has these have these responses where all the inhibitory interneurons and all the inhibition comes into play to kind of quiet everything down. So normally you've got this balance between excitation and inhibition. Many of the genes that are involved in epilepsy and developmental delay seem very directly involved. We have ion channels and genes that seem to be very directly involved in synaptic transmission and things like that. That sort of more clearly you could imagine are altering that balance between excitation and inhibition. And so it's not always obvious how that plays out at the cellular level and how each mutation actually leads to those changes. For epilepsy and seizures, many of the drugs that we use build up inhibition. So benzodiazepines, barbiturates, and even some of the sodium channel blockers, what they do is they either add more inhibition into the network or they tamp down excitation to try to shift that balance towards the inhibition. But if anyone has ever taken a benzodiazepine like Valium, Ativan, Xanax, or had a drink of alcohol, which can work with similar mechanisms, they make you sleepy, right? I mean, these drugs, they over inhibit and they can kind of shut things down. For people who have, you get this warning not to drive a motor vehicle if you have one of these drugs. And the reason is because they can impair your judgment and they can slow your response time and things like that. So, one of the things that we've thought about as a biomarker for how to see whether certain drugs work for these diseases is that there are some coarse measures of that balance between excitation and inhibition that you can sometimes get from EEG. So people have thought about using, they call it the EI ratio. They have thought about looking at the EI ratio as a marker to see if people respond to drugs and also to see how people develop over time. And then what we hope with these new therapies is that we'll see something clinically apparent, but also this balance between excitation and inhibition. If we can find some biomarkers that are measurable, that'll give us some other uh, early sign that the drugs may be working.
So do we have, so two questions. Do we have neurons that are specifically excitatory and inhibitory, or do all neurons serve both functions? And do you think this imbalance could potentially, let's say, may contribute to the sleep issues that we see in kids with MCHS?
Yeah. Yeah, let me answer both those questions. So each cell you have inhibitory cells and excitatory cells. Typically, we think of neurons as excitatory, and then there are these interneurons that are inhibitory. What ends up getting complicated, though, is that they're in a network. And so you can have an excitatory neuron that's connected to an inhibitory neuron. And so if that fires, it turns off inhibition and can end up being more excitatory. Or you can have inhibitory neurons attaching to themselves. And so the inhibitory neuron inhibits the inhibitory neuron. That can be excitatory. On the other hand, you can have inhibitory neurons connected to excitatory neurons. And then when that fires, that kind of quiets things down. And so the intuition about how the balance plays out at the cellular level is not always so obvious, but it is clear that you need both kinds of neurons, the excitatory and the inhibitory neurons, to have the kinds of circuits. And there's always this modulation and this interaction happening between the sort of the two broad classes of neurons. With regards to sleep, so sleep is interesting. Many kids with DEE, including the kids with MEF2, have sleep problems. The neurophysiology of sleep is complicated. There are these EEG signals we only see in sleep. So clearly there's all of this activity that's actually happening with sleep that's providing some function. It's clear that there's this communication happening with the deeper structures, the thalamus and the surface, the cortex, and these communications that are happening back and forth between those structures. And so when there's a developmental brain disorder and the neuronal communication is not what it's supposed to be, those sleep circuits can get disrupted. And it's not always obvious because who was I talking to? I've had some patients who have very profound developmental delay, very difficult to control epilepsy, but sleep is fine. And then there are other kids where they're a little delayed, but they're doing okay. Their seizures are well controlled, but sleep is the major issue. And it can be so disruptive, both for the kid and for the families. So, how the gene particularly relates to sleep, I don't think is obvious, at least not to me. But it was clear from our early conversations with James and with Isra that measuring sleep was very important for this group. And so we actually have two different sleep measures that we do. One was more designed for kids with sleep apnea, but it does measure sleep disruption. And then there's another measure that sort of talks about sleep habits and how long kids sleep and things like that. It was important to Isra and James and clearly to the community at large that we measure and think about sleep. And that way we'll know what the baselines are. So again, when the therapies come, we'll know if kids are doing better.
Right. Yeah, and independent of, I would imagine, like, the underlying physiology, just, like, having seizures probably, sets all kinds of things off that makes sleep harder, or having seizures while they sleep. So, it kind of, I'm sure it all gets very complex and layered and impossible to completely tease out to some degree, at least right now.
Yeah. And it's like it's an interesting moment in neurology because when I was a medical student and a resident, understanding these processes was all we could do. And so there was a lot of attention to sort of like really getting into the weeds, understanding the details. I think what I'm finding today, and I took a clinical path, so my training is very clinical, is that it's flipped a little bit where we want to understand the basic mechanisms, but but it's okay if we don't understand them fundamentally. Because if we have clinical measures and we have some therapy that restores the gene, then there's a tremendous enthusiasm to just get therapies into kids and see how they do. It's been fascinating to be on calls where you've got a basic scientist and a parent, for me as the clinician,
Mhm.
because the basic scientists are very conservative when it comes to clinical care. And they're like, maybe we should test a few more things before we put something into a kid. And the parents are like, go, 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 go. What do you got? Get it through FDA. I want to use it yesterday. And so for me as the clinician scientist, it's been really interesting to balance that because you get these sort of warnings from the basic scientists. It's like, you got to watch, right? Like there could be these big immune responses. There could be side effects, like you're going to get these antibodies. Balanced with the parent advocates who are really driving with this burning urgency to get these things into kids. And so my role is often to say to the scientists, we're all good with unknown. We know we know that we don't know, and we know that there's this uncertainty. And so my job is to then tease apart like is the hesitancy an issue with what we don't know and that's the uncertainty, or is the hesitancy around safety? And so
Mhm.
safety I have to take very seriously, because kids get sick. Like there have been deaths in some of these gene therapy trials. Like these are not benign interventions. But um, if we're comfortable on a safety standpoint and there's a therapy that has a reasonable chance to succeed, it's very clear from the parents that they want to understand the risks, but they're willing to take them on. And so, so for this therapy program in particular, my ear is very attuned to hear what are the safety issues that we need to worry about. Some safety issues are like, forget it, I can't do that because it's just the risk is too great. A lot of safety issues we can manage. We manage sick kids all the time. Kids are in the hospital all the time. And so it's like, well, what do we need to put into place? Do we need to use an immune therapy? Do we need to follow some labs? Do we need to say you need to be across the street? Here is my cell phone number. You will call me at 4 in the morning if your kid has a fever.
Right.
Those are the kinds of things that I can do as a clinician as we think about these trials so that the safety is addressed. And then look, my hope is that we nail it with this first round of therapeutics. But the history of medicine is that it takes a while. The stroke world, it took them decades before they found these clot busters that have really made a dramatic improvement in stroke recovery. And so with these DEEs, we're just at the beginning.
Mhm.
And so I think we all have our fingers crossed. We all are hoping for the best, and we hope that this is a years long process. But it could be decades. But with that urgency from the families, it's very clear that we have to start. We have to try. We have to do our best and see how kids do. And then if we nail it, we nail it. If we don't, then we have to think about what didn't work so that we can continue to evolve and improve our therapeutic ideas.
Yeah, and I think, it's important to remember too that, like, these therapeutics are probably relative to the things that we're eventually gonna develop, are probably not going to be very good, you know what I mean? I mean, it'll be life-changing for people who have these disorders, but, like, I don't y you're a doctor, I'm not, but I don't know of any medicine where they, like, developed one cure for a thing, and then when they were like, "Alright, we got it." You know what I mean? They're always pushing new categories of drugs and better ways to treat things with less side effects, so we're at the beginning of that process. In a lot of ways, I'm thankful for that because it means that a lot of the fixes are, I don't know what quite the right word is, because 'cause they're certainly not simple, but there's a lot of things that are still to be discovered. If we had worked on this problem for 100 years and we still were pulling our hair out, then that would really be a problem. But a lot of this stuff, if we just trust in the scientific process, the answers will uncover themselves.
Yeah, that's right. And I think what's been really inspiring to me is how dedicated everyone is. I mean, families, they've been coming from all over the country to come visit us. We've done drug studies where people have traveled from far.
Mm.
And then it makes sense because we've got some therapeutics that no one else has. But when people come for natural history studies, it's really touching. I mean, I have to tell you, it's quite sort of inspiring and moving that families, because we don't we're not providing a therapy. They're just coming for us to look and to measure. And so for the community to have gotten together and for everyone to be signing up for this particular study, it's really wonderful. And the families really get it. I have to say, I'm very impressed and moved when people come for this. But to your point, I think about there's two different drugs that kind of are on my mind. There's a disease called spinal muscular atrophy, SMA. I think, Lou Gehrig's disease is a more well-known version, where normal adults sort of have this degenerative process. They end up in wheelchairs because the motor neurons in their spinal cord degenerate. There's a flavor of that can happen in babies where the motor neurons degenerate very, very early in life. And this was a horrible, horrible disease where I think many people of my generation and earlier took care of these kids, and they're heartbreaking cases where they're cognitively okay, but their bodies are failing them. So for that disease, there's two gene therapies. There's an ASO and an AAV. An ASO is a little of RNA that kind of tricks the body into making more of the target protein. And then an AAV is like a virus that infects the body and then makes the body make the protein. Instead of making more viruses, it makes the protein that you want. So they started using that for spinal muscular atrophy. And then kids who we expected would never walk now walk. I mean,
Oh,
it's
that's incredible.
home run. It's like
Yeah.
amazing, right? So we have that on one end. And then there's another disorder, Menkes disease, where it's an enzyme deficiency. There's an enzyme that processes copper, and these kids don't make it. So you can give that enzyme to the kids, and if you get them in the first few months of life, they do okay. They walk and talk and have normal lives. But for those kids, if you get them after they're two, it doesn't. The ship has sailed. The
Mhm.
developmental delays are there, and there's nothing. There's essentially very little benefit. And so as we think about MEF2C and MCHS, I don't know where we're gonna land, right?
Mhm.
Is this gonna end up being a therapy that we can give to older kids and they see benefit, that actually we get some improvement for them? Or is this gonna be something you gotta do really, really early to have benefit? And is it gonna be enough? The other thing we worry about is, are there processes that happen before you're born,
Mhm.
set in stone and can't be fixed? So I am hopeful that the hope for me is coming from the Dravet syndrome trials. Dravet syndrome is another developmental and epileptic encephalopathy. Their seizures are typically much worse than the MCHS kids, um, but they are farthest along in this world with an AAV and an ASO therapies. And some of those early reports are very, very promising, where kids are maybe starting to make some developmental gains, having nice seizure control. And so as I kind of, when I'm working on a study, when I'm writing, I'm seeing the kids, I'm inspired by that story. Like I'm seeing that it's working for some of these disorders. We're making progress, and kids are benefiting from this whole approach. And so I'm hoping that we're going to be more like SMA and less like Menkes.
Yeah. Yeah, I agree, and I'm optimistic about that. But at the same time, this isn't a conversation I've had with a lot of other parents, but like we still, as being so early on in the discovery of this, like even if by the time they find a treatment, it's too late for Leo. Like I'm still we have the opportunity to have an outsized effect on, you know, there's thousands of people probably who have a MF2C related variant in total and just are undiagnosed. And then as time goes on, so you really have a chance to have a profound impact on the world by participating in this stuff.
Yeah. And hearing that from families is really inspiring. It's a total motivator. I mean,
Mm,
you know, it's like academic medicine. It's like you wear 10 hats all the time. Speaking with families, meeting with families, hearing their stories, working with the foundations, working with Istra and James has really been a highlight. It's really wonderful to do because everyone wants the same thing, right? Everyone's aligned. Everyone's lined up, and they're trying to do the same thing for the kids. So it's really wonderful.
yeah, that's great. So tell people, sort of what the study actually looks like as far as from a participant, like, if they signed up, what could they expect to go through?
Yeah. So we were thoughtful about this because flying to New York all the time is a big burden. And we wanted to be able to capture enough information for us to understand what was happening without adding all this burden to families. And so we said, listen, if we get 4 visits, we're gonna see what those curves look like. And then, you know, we had this big conversation about older versus younger kids. Should we even enroll some of the older kids? And I think what I heard from James and Isra in particular is that we need to include them. They have stories to tell, and we need to know where they're at so that if we end up offering it to older people, we can see again those benefits. So we ended up coming up with a little bit of an innovative study design where we said if you're 15 or younger, those are people we know are developing. That there's going to be like a normal kid, you see them every 6 months, they're gonna be changes. So for those kids, let's go all in. Let's bring them to New York. Let's do 4 visits. Let's do it 6 months apart, and we'll do everything. We'll, the neurologist, the developmental pediatrician, the occupationist, the occupational therapist, the genetic counselor, and we'll get all of that data. We'll get the EEG once we get that device activated. And so but we'll just do 4 visits. So if you sign up for the in-person section, you fly to New York. We have $1,500 for every visit to help defray the airline and the travel cost and the lodging. And those kids are with us for, you know, 4 or 5 hours on a Monday or Tuesday morning, and we do everything. And then they come back at 6 months, 12 months, and at 18 months. So we get 4 total visits. We wanted to include the older kids, and so for 16 and older, we do 2 visits a year apart, and we do that virtually. Um, those visits are more about hearing your story, understanding what things look like, and then,
So, sorry to interrupt you,
yeah.
but you say 16, so any, like, adults could be included too? It's not just 16 and old? Because I know I'm guilty of it too. We use the term kids because they're all somebody's kids, but, just to be clear, if someone has an adult in their life with MCHS, they can enroll too.
Absolutely, 100%, and we're eager for those stories to meet those adults, to understand what their lives look like, um, and to see where their development is. Both the in-person and those virtual cohorts, they get a long list of assessments that they fill out on their own. In particular, there's something called the Vineland, and it's so funny. We hear from families like, "I hate doing all this," because a lot of the questions in some of these assessments are the same.
Mhm.
But they're so valuable. The Vineland in particular is lovely because they've gone through 4 editions of it. It's well normed, the statistics are well worked out. And so when we collect that data and we bring it to the FDA, they've seen this before. We're not making up something new. It's a well-established set of measurements. And so the idea with the older children and the adults, as you say, is that we'll look at them twice, a year apart to understand, what their level of function is, and then how much that kind of varies over time. Um, and our goal is that, and our goal is to have. I think we're going to enroll 36 in the in person and 32 in the virtual. Our goal is that at the end we'll have this rich set of trajectories for all these kids and adults and understand what the disease looks like across the lifespan. So when we go to FDA with Dr. Cowan's labs therapeutics, we can say we've got a drug, we think it's going to work based on the animal data, we think it's safe based on the animal data. This is what kids do normally in adults, and we think that we're going to measure a bump above the baseline, and that's what we're looking for.
Just from a community aspect,
Yeah.
I know there are a lot of people who have a lot of questions about what that adult end of the spectrum will be,
Mhm.
and there's not really any information on it. Independent of the therapeutics, I know there's a lot of people to be really interested in just knowing what adult life looks like for their kids. And then things like MEF2C has been tied, not necessarily in the same ways that it applies to our children, but MEF2C has been tied to dementia and Alzheimer's, for example. So, do they have an increased risk of things like that? Just different things,
Right.
questions that run through parents' heads that there's just not good answers for yet. So, I'm really excited to hear all that as well.
Yeah, I agree. We know, like, for example, in Down syndrome, that they have early Alzheimer's.
Mhm.
And so, I think a lot of times we hear from parents of children with these rare disorders, exactly as you say, like, what does the future hold? And I'm hopeful, well, I'm confident that we'll be able to answer some of that through our interviews with the adults. We have a bunch of forms we fill out for those interviews, but it's also a conversation. And so I take like a medical history. So we're
Mhm.
taking a lot of qualitative data as well to understand what people's lives are like.
Yeah, that's great. All right. So, in closing here, because I know you got another meeting soon, just kind of give our audience your quick pitch on, how they can sign up for the study, what to sort of expect when they show up, how you run them through, and yeah, anything else you'd like the community to know.
Sure. Yeah, let me get the link. I should have had it up earlier.
That's all right.
I will get it to you, and hopefully you can add it with the so we can give it to people. But the way that we've been doing this is that we have a link that goes to a survey that gives us just very high level information and contact info, and then we'll reach out to you to get you involved. We've been focusing mostly on U.S. patients to start, But now that we've got our clinic up and running, we're starting to look internationally and see how we can engage with the larger community. In person is flying to New York. Again, we have the $1,500 per visit to help defray the costs, and it gets you a trip to New York. You can have a pastrami sandwich, you can see a Broadway show, whatever you want to do.
Mhm.
The clinic is not, we designed it to be not so burdensome. Some of my colleagues will do like 2-day clinics or 3-day clinics. We try to get everything done in sort of a morning and sometimes part of the early afternoon. And the experience is like, we get you in a room and then it's sort of rotating cast of clinicians who will come in. I see you. We have our genetic counselor, physiatrist, developmental pediatrician, our research coordinators, occupational therapist. Everyone comes in, do their evaluation and fill things out. And then the EEG machine will add that as another piece of data that we'll start collecting in the fall. And then we do that every 6 months for 4 visits. And then for the older children and for the adults, it's just a Zoom. It's 1 hour twice a year apart, right? And so as well as some of the online surveys that we send out to people. So it's intended to not be burdensome. It's a tremendous resource for the community for us to have this data to help us with the therapeutics. And then the way that you sign up is that we have this red cap link, which I should be saying it out loud, but I'll give it to you to.
You can send it to me and I'll put it in the description.
So it'll be in there. So if you just click on that link, it'll get you to our survey and you can give us the information. We started just with, I think, Tuesday mornings, then we added another day. So now it's Monday or Tuesday mornings. We've opened up a bunch of those visits throughout the fall. We're still scheduling people for the fall. And then the winter and spring is wide open. And it's a tremendous gift for us to have this very engaged and enthusiastic community to teach us about their disease, to teach us about this gene. And it's been humbling for me to be part of this. And, and I'm not the guy making the therapeutics. So our role is to kind of build that foundation so that as those therapeutics are developed, it's going to be a much easier conversation with the FDA to get them, approved for early trials and then hopefully approved for general use.
Awesome. Yeah. All right. Well, thank you so much for your time, Dr. Grinspan. And thanks to our audience, as always, for listening. mef2ccast.com, mef2cast.com. You can find everything there or find us on Facebook at the mef2ccast. Thanks, everybody.